Hello everyone, welcome back to this channel. So today we are going to study heart failure. Now how to define heart failure? Basically, heart failure is a complex clinical syndrome identified as current or prior characteristic symptoms. What are the symptoms? Symptoms like breathing difficulty and fatigue, right? With the evidence of cardiac dysfunction. And what are those evidence that we can get? It is an abnormal LV filling, or it could be right ventricular filling, which is abnormal, or the pressure in left ventricle and right ventricle. So the characteristic symptoms and the evidence of cardiac dysfunction would be the definition of heart failure, right? In a simple wording, it is a condition in which heart cannot pump enough blood to meet body's need, right? Leading to the symptoms like breathlessness and fatigue. Okay. Now remember, we classify heart failure depending upon the ejection fraction. According to ejection fraction, the classification of heart failure is into three parts. The first part is heart failure with reduced ejection fraction, in which the ejection fraction is less than 40%. The second one is heart failure with mid-range ejection fraction, in which the ejection fraction is around 41 to 49%. And the third one is heart failure with preserved ejection fraction. In this case, the ejection fraction is more than 50%, which is almost a normal, but still there is a heart failure. Remember, heart failure with reduced ejection fraction and mid-range ejection fraction is mostly due to ischemic cardiomyopathy. Okay. On the other hand, heart failure with preserved ejection fraction is mostly associated with HOCM and restrictive type of cardiomyopathy. Now let's study about the stages. So there are 4 stages of heart failure, which is divided into A, B, C and D. Okay. For the stage 1, that is stage A, the patient is at the heart failure risk, but there is no symptom as such. Keep in mind, there is no structural heart disease, right? Also, there is no symptoms. There are just risk factors. And what are those risk factors? These are hypertension, these are diabetes mellitus, these are atherosclerosis, there are OSA, right? So these are the risk factors that is associated with stage A. Now what about the stage B? So stage B is also known as pre-heart failure. Now why it is known as a pre-heart failure? Because there is a structural disease and it is a condition that is prior to heart failure. So that's why we call this stage B as a pre-heart failure. So there may be raised biomarker without symptoms. So in this stage of B, there are structural heart disease, but there is no symptoms. Next is a stage C. Now what we get in stage C is there is a symptomatic heart failure. There is a structural heart disease and there is a symptoms as well. But this condition can be managed with the medications, right? So whenever we use our 4 pillars of medication, the stage C heart failure will be responding, right? But on the other hand, the stage D is a somewhat advanced heart failure, which is not managed by medication. Medication in the sense of medical management. So this stage needs dialysis to improve its condition. Coming to pathophysiology and clinical features, the important thing here is the systolic heart failure and the diastolic heart failure. Remember, all the symptoms that is associated with the heart failure are coming from this systolic and the diastolic failure symptoms. Now regarding systolic heart failure, it is called as a forward failure symptoms because there is a left ventricular hypertrophy. Now the key point for this systolic heart failure is a myocardial injury, right? So what are the causes of myocardial injury? The ischemic heart disease, dilated cardiomyopathy, myocarditis, chronic hypertension, and there are few valvular heart disease like AR, AS and MR. The severe AS, AR, MR will also cause myocardial injury, which leads to this heart failure. Due to this myocardial injury, there is a decreased left ventricle contractibility, right? So there is a decrease in systolic function of left ventricle, right? Due to this decreased left ventricular contractibility, there is a reduced ejection fraction, which results into decrease in stroke volume and cardiac output, right? So the next thing is, due to this decreased cardiac output, there is a perfusion failure, right? The perfusion towards the internal organs are decreased, which causes ischemia to other organs as well, right? So depending upon the organ that has been compromised with the perfusion, we will get the symptoms. So whenever there is a decreased cerebral perfusion, we get fatigue, weakness, dizziness, and confusion. When there is a decreased perfusion to skeletal muscle, we will get muscle intolerance and muscle weakness. What about the renal perfusion? As soon as there is decrease in a renal perfusion, there is activation of RAS, right? This RAS activation will create the sodium retention and the water retention so as to increase preload and congestion, which will again worsen the heart failure, right? For all of this, there is a compensatory sympathetic nervous system activation, which causes tachycardia, peripheral vasoconstriction, and there is a cold extremity and sweating, right? This will increase the afterload and this will worsen the heart failure, right? The pulmonary effect consisting of dyspnea on exertion and reduced exercise tolerance, right? So there are three mechanisms. The first one is sympathetic nervous system. There is RAS and there is ADH. This chronic neurohormonal activation leads to worsening of heart failure. And what are the mechanism behind it? There is a sodium water retention, there is a vasoconstriction from sympathetic nervous system, and due to this all, there is a remodeling of heart, right? And this remodeling is by the hypertrophy, followed by fibrosis, and followed by chamber dilatation, right? So this remodeling will also decrease the systolic function. So there is a constant cycle in which the heart falls and there is a continuous systolic dysfunction that we get, right? So the key forward failure symptoms are fatigue, exercise intolerance due to muscle perfusion problem. There is dizziness and syncope due to decreased cerebral perfusion. There is cold clammy extremities due to sympathetic nervous system. There is oliguria due to RAS activation and due to decreased renal perfusion. Then there is a tachycardia, right, and dyspnea on exertion. So this is systolic failure function, and it is mostly associated with reduced ejection fraction heart. The next concept is important diastolic failure symptoms. The main reason behind this diastolic failure symptoms is there is a stiff and non-compliant LV, right? And what is the reason behind this stiff and non-compliant LV? It is a chronic hypertension, it is left ventricular hypertrophy, it is diabetes mellitus, and it is ischemia. This leads to impaired ventricular filling, which causes increased filling pressure like left ventricular end diastolic pressure. Okay, this again causes increased pressure in atria, and this atrial increase in pressure will cause atrial fibrillation. So one of the symptoms of diastolic failure symptoms is atrial fibrillation. Due to this increased filling pressure, there is a congestion of pulmonary veins, right? And this results into the pulmonary edema and their symptoms. Now, what are the diastolic failure symptoms? It is most of the dyspnea, the different types of dyspnea. This includes orthopnea, PND, exercise intolerance, tachypnea, right? So this includes diastolic failure symptoms. Now you must have a question how to diagnose this heart failure. Now the diagnosis of heart failure is totally clinical, but there is a criteria that is a modified Framingham criteria to diagnose heart failure. This includes the major criterias and the minor criterias. Now I don't think examiner will ask you about the individual symptoms from this major criteria and minor criteria. So I will leave it for a while, but I think examiner could ask you about the requirements. So either two major criteria or one major plus two minor criteria should be there to diagnose heart failure. So keep in mind, the modified Framingham criteria is for heart failure diagnosis, and it includes major and minor criteria. These are the major and minor criteria. It is always recommended to remember, but it is not possible to remember everything. So I'm just sticking up with the two major criteria and one major or two minor criteria to diagnose heart failure. Okay, then we can do echocardiography, that is echo. In this we will get the ejection fraction and the structural assessment of heart, and with this we can diagnose the heart failure as well. The second test is BNP and NT-proBNP. These are the diagnostic markers for heart failure. Now, what are the normal range of BNP? The normal range for BNP is around less than 100 Pg per ml. Pg stands for picogram. For the range of 100 to 500 picogram per ml, the result is equivocal. Right? What do you mean by this? There is a chance of heart failure and there is a possibility that there is no heart failure. Okay. More than 500 Pg per ml, it is usually associated with heart failure. Right? What about the NT-proBNP? So NT-proBNP is associated with the maximum sensitivity and the specificity for the diagnosis of heart failure. Traditionally, we used to use this BNP only, but nowadays most of the labs and most of the emergency and ICUs are equipped with this NT-proBNP with the ABG as well to diagnose heart failure. So the level more than 300 Pg per ml of this NT-proBNP is usually associated with heart failure. Coming to the third one, that is a chest X-ray, we can diagnose pulmonary congestion here. I hope you can appreciate this curly B lines and peribronchial cuffing. Also, you can appreciate in this X-ray about bat wing appearance. Right? There is one more investigation that we can do for the pulmonary edema, and it is POCUS, which includes blue protocol for bedside lung ultrasound. Right? We will study this in our upcoming sessions, but as of now, you must remember that there is a investigation like POCUS ultrasound that we can do bedside, and it is called a blue protocol. Next, let's discuss treatment protocol for heart failure. Now, what is the treatment protocol for heart failure? The important thing here is there is a 4 fundamental therapies. We called it as a Fantastic Four, or we also called it as a 4 pillars. So remember that there are 4 therapies which are the pillars for treatment of heart failure. The first one is ARNI, that is angiotensin receptor plus neprilysin inhibitors. So this is the first line of therapy that we should start for the patient of heart failure. If this ARNI is not tolerable by the patient, then we will start the ACE inhibitors, right? And after that, we will start ARB inhibitors. Now, what are those ARNI? Drugs like sacubitril and valsartan are ARNI which are we use for the first line of treatment for heart failure. Okay. Now, one thing I forget to mention here is the reason behind to call this 4 line of drugs as a 4 pillars or Fantastic Four. So these 4 drugs or 4 therapies are associated with the maximum improvement for heart failure patients, like decrease hospitalization. The second one is decrease remodeling. Third one is decrease mortality, right? So these are the important key advantages that are associated with these 4 fundamental therapies. That's why it is always recommended to start the patient for these 4 fundamental therapies. Now, there is very common question in NEET PG. They will ask you which of the following drug is not associated with decreased remodeling for heart failure. And the answer usually is diuretics. So diuretics are usually not associated with decrease in remodeling. So ARNI like sacubitril and valsartan to be started on first therapy. The second one is AC inhibitors. If not tolerated by ARNI, then we start AC inhibitors like enalapril. Okay. If the patient is again not tolerable to these AC inhibitors, we will start with ARB and the ARB like losartan. So the benefit we have discussed, it is associated with the decrease in mortality, decrease in remodeling and decrease hospitalization, which is one of the most important characteristic features for this four fundamental therapies, right? Coming to the second drug, that is a beta blocker. Drugs like carvedilol, metoprolol and bisoprolol plays an important role for the treatment of heart failure. Now the key point one has to remember with respect to this beta blocker in heart failure is these drugs to be started only when the patient is euvolemic. Now what is the reason behind this start of beta blocker in only euvolemic stable patient? So what is the basic mechanism of beta blocker? It decreases heart rate, right? So suppose if the patient is having a hypervolemia and there is a decreased heart rate, what will be the next adverse effect that can caused by this? It is pulmonary congestion. So this pulmonary congestion will cause due to beta blocker in hypervolemic patient. So remember one thing, that beta blocker has to be started only if the patient is euvolemic, and this is very high yield topic for the NEET PG. Again, if the patient is hypervolemic, then what we will do? We will start with this patient on diuretics, right? And after getting evolemia, we will start this patient on beta blocker, right? So this is something we must understand and we must remember about the beta blocker. The third drug is mineralocorticoid receptor antagonist, that is MRA. So fundamentally we use spironolactone and eplerenone in our daily practice, and these are very mild diuretics which is associated with potassium sparing effect. Now recently there is one new study about finerenone. So what is finerenone? Finerenone is new non-steroidal MRA, and studies has found that it has a superior action to spironolactone and eplerenone, and the condition in which it is superior is it decreases gynecomastia. It is associated with the decreased chance of endocrine dysfunction. It has a better cardiorenal protection, and it is also associated with decreased chance of fibrosis, right? So these are few points in which the finerenone is more suitable rather than spironolactone and eplerenone. Now regarding our fourth drug like SGLT2 inhibitors, the one thing is to remember is that heart failure with mid-range ejection fraction shows that the treatment for this heart failure is mostly effective with SGLT2 inhibitors. So heart failure with mid-range ejection fraction, the SGLT2 to be started first than ARNI. Okay, this is the only key point to remember for SGLT2 inhibitors. The drugs like dapagliflozin, empagliflozin are the drug of choices for. The next drug is diuretics. Now diuretics are mostly for symptoms relief, and these drugs are nothing to do with the remodeling, right? So remodeling is not associated with the diuretics. Drugs like furosemide and torsemide are used for the symptom relief. These drugs are used for pulmonary edema, pedal edema and congestion, right? So these are the four pillars for the treatment of heart failure. Moving forward to the refractory heart failure. Now what is the refractory heart failure? Suppose you have started patient on beta blocker and you have achieved a maximum tolerable dose of beta blocker, and still there is a heart rate more than 70. So you have used ARNI, you have used beta blocker, you have used MRA, SGLT2 inhibitors, and you have tried everything, and still there is a heart rate more than 70 per beats minute. Then what we will do? We will start this patient on ivabradine. So ivabradine is a funny current inhibitors, and even after starting this ivabradine, still the patient is symptomatic. Like still the patient is having breathlessness, or the patient is having fatigue, then this condition we will call it as a refractory heart failure, right? Now, depending upon the QRS complex, the width of QRS complex, we will define the treatment choice for this particular heart failure. For the wide QRS complex, we will start this patient on cardiac resynchronization therapy, that is CRT, and we will also advise patient for cardiac transplant. So there might be a question in which they will explain the patient is having heart rate more than 70 with the symptoms even after giving ivabradine, and the definitive treatment of choice for this particular heart failure is associated with the following options, and the most suitable option for this question would be cardiac transplant, right? Now the QRS complex is normal. We will start this patient with left ventricular assist device, that is LVAD, or it can be started with implantable cardioverter defibrillator, right? So this is about the refractory heart failure. Now what happens in sometimes this heart failure patient can land up in emergency with the worsening of this heart failure symptoms, and this is called as acute decompensated heart failure. How to define this acute decompensated heart failure, that is ADHF? It is the worsening of heart failure symptoms requiring urgent hospitalization, and this mostly associated with few triggering point like infection, or there could be hypertension crisis, or there could be dehydration. So the causes for ADHF are acute coronary syndrome, that is MI, arrhythmias, uncontrolled hypertension which increases the afterload, and so the heart failure symptoms aggravated. The infection and sepsis can cause ADHF. Again, if the patient is non-compliance with the medication, or there is excessive salt or fluid intake which leads to pulmonary congestion which land up into the ADHF. Also, if the patient is consistently having a renal failure or history of renal failure, one of the cause is pulmonary embolism as well. The worsening of valvular heart disease is also associated with heart failure patients. Then there is a anemia, thyroid disorder, and alcohol and cardiotoxic drugs as well, right? So this is a ADHF. Now let's understand the classification and the clinical feature and the treatment options for this acute decompensated heart failure. Now regarding the classification and the management of ADHF, ADHF is classified under the 4 heads, usually for the 4 heads. The first one is mild to moderate ADHF. The second one is hypertensive ADHF. The third one is ADHF with acute pulmonary edema. And the fourth one is associated with the cardiogenic shock. The ADHF that is associated with the cardiogenic shock, we will understand and we will study this topic in later stages when we are discussing the shock. As of now, we will study this mild to moderate hypertensive and acute pulmonary edema. So what is the most important cause for mild to moderate ADHF is the precipitating factor. This mild to moderate ADHF is precipitated by LRTI, and the clinical features includes progressive dyspnea, right-sided congestive symptoms like JVP, tender enlarged liver, and edema. On examination, we can get cardiomegaly, MR, and S3 sound, right? What about the management? Usually we start this patient on symptomatic treatment like torsemide at the dose of 5 to 10 mg. Right? Let's talk about the hypertensive ADHF. Now hypertensive ADHF is very important in terms of exam as well. The hypertensive ADHF is mostly presented with underlying heart failure with preserved ejection fraction. What exactly happens in this condition is there is a sudden hypertension which leads to increased afterload. Since there is a pre-existing heart disease, and if the heart is exposed to sudden increase in afterload, there is a worsening of heart failure, right? So it is a progressive dyspnea associated with uncontrolled hypertension, and this failure is usually due to diastolic failure symptoms. Get it? Now what about the management of this hypertensive ADHF? The most important management in this condition is IV diuretics and oral hypertensive, or we can start with the IV NTG as well, right? So this is about the hypertensive ADHF. Now let's talk about ADHF associated with acute pulmonary edema. So in this case, the breathlessness is most common symptoms, right? And the patient will complain that he's not able to sit up or can't lie down, and he has so much extreme breathlessness that he's just restless and gasping for air hunger, associated with the diaphoresis as well, right? So there will be the signs like tachypnea more than 30, hypertensive crisis, and creeps all over the lung fields, and the frothy sputum and hemoptysis. Now, how to manage this condition? So IV diuretics is the key point for this management of this acute pulmonary edema, along with nitroglycerin. Also, we use oxygen and non-invasive ventilation. Now, understand that all the patients with acute decompensated heart failure, the airway must be secured. Please remember this key point. Most of the ADHF patient will be presenting to you with the severe breathing difficulty, and at this point we have to start this patient on CPAP or BiPAP. Now what is this CPAP and this is BiPAP? So it is a continuous or bilevel. In short, for every ADHF patient we have to take care for the airway, right? And for this airway securement, we have to start this patient on CPAP or BiPAP depending upon the presentation. So if the patient is coming with the severe breathlessness and gasping for air hunger, also the monitor shows there is a decreased SpO2, then this patient is eligible for BiPAP or CPAP. This is called as a positive pressure ventilation. Positive pressure ventilation. So we have to start this patient on positive pressure ventilation. Okay, so this is one of the key point that you must remember in case of acute decompensated heart failure, right? So this is the summary that we must remember. Acute decompensated heart failure associated with the cardiogenic shock. We will study this topic in later videos where we are going to study the shock, right? So this is all about the heart failure. I hope this will help you in your exam. Watching. See you on the next video.